Welcome to today's discussion on ongoing professional practice evaluation, OPPE, and focused professional practice evaluation, FPPE. During this discussion, we're going to be discussing an overview of OPPE and FPPE, considerations when developing OPPE and FPPE, how to utilize the information and how to document its use, information protected by 38 U.S.C. 5705, and the general 6 competencies to be addressed in the OPPE process and examples of each. Albert Einstein said, "Not everything that can be counted counts, and not everything that counts can be counted." This is a wonderful thing to keep in mind as we proceed in this presentation. Peter Drucker, who was considered by many to be the father of modern management, said, "We can't manage what we can't measure." But measurement doesn't always mean that we count things. Measuring success can't always be done with numbers alone. The key to successful OPPE and FPPE programs is identifying indicators that are meaningful and not counting things for the sake of filling in a box. So today we're going to talk about the OPPE and FPPE process and different ways that they can be approached in a meaningful way. So where did this start? In 2007, the Joint Commission implemented. So where did this start? In 2007, the Joint Commission implemented a renewed emphasis on the measurement of professional competency for medical staff members. This is when they introduced the two definitions. Focused Provider Practice Evaluation, or FPPE, is a focused review involving monitoring, analyzing, and understanding those special circumstances which require further evaluation. In FPPE, there is a defined start and stop. Ongoing Provider Practice Evaluation, or OPPE, was defined that at the time of renewal of privileges, the organized medical staff evaluates individuals for their continued ability to provide quality care, treatment, and services for the privileges requested as defined by the medical staff bylaws. In contrast to FPPE, OPPE does not have a defined stop. It does not stop until the clinical affiliation with the provider has ended. So let's start out with a discussion of FPPE, or Focused Professional Practice Evaluation. FPPE, when is it used? It's used for two purposes. When a provider initially requests privileges, such as a new provider who is coming to your facility requesting privileges, or when an existing provider requests a new privilege. The second time that FPPE is used is when a trigger is met for an existing provider that raises a concern of their current ability to provide safe, high-quality patient care. And this, in other words, is often called an FPPE for cause. Some may find that some service chiefs or chief of staff may want to exempt experienced providers from FPPE. It is important to realize that there is no such thing as exemptions. The FPPE process is required for all new privileges at your facility. However, the medical staff may want to define their criteria a little differently for different levels of documented training and experience. One example of this may be someone coming from a residency program to your facility. A provider coming from an outside residency program may have different criteria since they are unknown to you versus a provider who's coming from your organization's residency program who has been working at your facility for years and is well known to your staff. Another example of where criteria may be a little different is providers coming with a documented record of performance of privileges and its associated outcome versus providers coming with no record of performance or privilege and its associated outcome. However the FPPE is defined, it has to be fair and objective and uniformly applied. If you're going to define differences or pre-qualifying criteria, you must be careful to validate that the information given and ensure that it is accurate and objective. Always err on the side of patient care for a more intense or focused FPPE. Do not base it solely on the provider's report of how many they have done of something. You always have to confirm what you are told. We're going to discuss the triggered FPPE, otherwise called FPPE for cause, later in this section. Considerations for FPPE. Criteria for FPPE must be developed by the services and approved by the Executive Committee of the medical staff prior to implementation and must be consistently used for all specialists covered by the approved criteria. Results must be documented and reported to the Executive Committee of the medical staff for recommendation of further action. For example, a provider may be recommended to continue on the FPPE for a successful outcome to just be converted to the OPPE process or potential action on a privilege such as revocation. And we'll discuss this further in the presentation as well. Note that you need to have a tracking system in place for timely reporting of actions and closures of FPPE to your Executive Committee of the medical staff. When the FPPE is assigned to a provider, there must be time frames and they must be tracked and met and reported back to the Executive Committee of the medical staff in a timely manner. Consistency in the FPPE process is the key and cannot be overemphasized. You should be able to show a provider that there is no bias and be able to show them the approved FPPE criteria that is applied throughout your facility. Some more considerations in FPPE. When you're developing FPPE criteria, it is important in advance if you need assistance in the monitoring process from a professional outside of your facility. Examples of when you might need to consider this is when there is no other qualified provider on staff. For example, you only have one specialist of that type or a very small number of specialists in the department where there may be conflicts of interest or conflicts or lack of objectivity. In creating the plan for reaching beyond your facility, your chief of staff may want to go to the VISN chief medical officer, or the service chief may want to go to the VISN lead for that specialty for assistance. There may be times that the leadership may need to reach to a national program office in order to ensure objectivity. For example, there may not be many podiatrists or optometrists in your VISN, so reaching out to the chief consultant for either of those clinical areas could be considered appropriate. Let's talk a little bit about the difference between an FPPE and a focused review. Both are management reviews, however, they are not the same thing. There is often confusion over what an FPPE is and what a focused clinical review is and how they differ. If someone trips one of your defined triggers, which we'll talk about later in this presentation, the first thing to do is conduct a focused clinical review to determine if there is an issue. If the original information is protected under the Quality Management Confidentiality Regulations, 38 U.S.C. 5705, the information will have to be rediscovered. But what and how reviewing and investigating needs to be done depends on the issue at hand. If you establish that there is an issue, then leadership needs to decide if the provider should have the opportunity to improve in a structured way, the FPPE. If the provider needs more observation, the FPPE. If it's of serious enough concern that there is minimal to no expectation that the provider can or will improve, leadership may choose to move towards reduction or revocation of the privilege directly and not go through the FPPE process. But the reason that we have the FPPE and OPPE process is to not have an issue identified late in the game. The OPPE, which we'll talk about soon, is designed to hopefully identify questions or concerns early in the process, before they become issues and at a point where they are given the opportunity in a defined structure with defined expectation, an FPPE, the provider will demonstrate improvement and everybody wins. The facility and our patients win because the provider is returned to full service, and the provider wins because they get to deliver the quality care that we hired them for. Let's spend a little bit more time talking about focused reviews. As we discussed in the previous slide, a focused review is triggered, and it is a type of management review. It is not protected. It is used for fact-finding, and therefore is not 38 U.S.C. 5705 protected. The purpose of the focused review is to fairly and objectively identify the concerns that are triggered and are substantiated. It is also time to clarify any conflicting evidence. It's a time to identify if there's an isolated issue with provider's practice. If there was an issue with the system which contributed to the poor outcomes, and/or is there a concern about the provider's professional competency or professional competence, or otherwise called clinical care concerns. If the focus review finds that the concerns are not substantiated, the decision may be to take no further action and continue the provider on the current OPPE. There may be system improvements identified which need to be addressed. And there may be true concerns of the provider's ability to perform one or more privileges, which may lead to an FPPE for cause, which we will discuss shortly. So when are management reviews triggered? And by management reviews, again, we're discussing focused reviews and FPPE. So we cannot emphasize enough that the triggers, as with the FPPE and OPPE indicators, must be predefined and approved by the executive committee of the medical staff and approved by the director. In identifying the triggers for the service chief should probably work with several different individuals and departments from around the medical center, including their own professional staff. Information gathering might include asking what is already being collected and monitored, asking the quality performance department what criteria they're already reviewing, and asking services like DSS what they have available to help demonstrate performance and outcomes. Once the service chief develops the triggers they would recommend, the recommendation then goes to the executive committee of the medical staff, who in turn make a final recommendation to the director for approval. The triggers that are to be identified are ones that indicate when a provider may fall outside of the normal standards and benchmarks. There should be key triggers identified which may result from a single event or from a clinical practice trend. Triggers must be used consistently and objectively. Any professional who finds themselves in an FPPE for cause review as a result of a trigger being met should be able to be referred to a local document which clearly identifies which trigger was met and why this process is happening. There may be identified triggers that can possibly be the same across services, and some triggers that may be service or specialty specific. There are three primary types of triggers for management reviews. One is a significant departure from an established practice or pattern. The second type is a failure to meet screening criteria benchmarks established by the medical staff. And a third is a concern raised about care provided by a member of the medical staff or a member of the treatment team. Some examples of possible triggers, and again these are just examples, might be more than level 2 peer review ratings within a 12-month rolling period, or the total from all peer reviews during a rolling period is 5 or more. A higher complication rate than the nationally recognized benchmark or your facility's benchmark. Higher than expected rates of return to surgery. Higher than expected rates of readmission within X number of days. A small number of specialized procedures over an extended time that might raise concern of continued competence, or significant involvement in a sentinel event. So we've talked about criteria for identifying triggers for FPP cause. Let's go back and talk about the general criteria for FPP indicators for providers who are new to your facility and requesting new privileges, or an existing provider who's adding a privilege. First, the Joint Commission does not require a time period as a measurement. Many think that FPPE should be completed within X amount of weeks or X amount of months. Other factors should be taken into consideration versus just a time period. For example, it may be more appropriate to consider a different approach for high volume versus low volume privileges. An example of this might be for pertinence reviews and direct review of a new primary care provider who assumes a full clinic load. A review of a significant number of charts and direct observation can be completed in a fairly short period of time for this provider. In contrast, you may have a surgical specialist who is privileged to do a very specialized procedure with an anticipated volume of only 10 per year. In this case, the number of cases to be reviewed is much more reasonable because they would be occurring over a very large amount of time. Other considerations for your FPPE criteria and the amount to be reviewed or the time frame to be reviewed would be high risk versus low risk privileges. A 10% review of a low risk procedure may be appropriate, where a 100% review may be appropriate for a very specialized and high risk procedure. So now we're in the presentation, we're at the point where the FPPE indicators have been identified, the information's been gathered, and the service chief has evaluated the information and is ready to make a recommendation to the Executive Committee of Medical Staff. At this point, the FPPE analysis must be written by whomever was assigned to perform the review. The written recommendation may be to continue the FPPE for further monitoring. If this is the recommendation, caution should be made to ensure that it is for a short term and for a good reason. A recommendation to continue FPPE for further monitoring should not be used as a mechanism for simply delaying the inevitable and delaying a tough decision that needs to be made. In these cases, the second recommendation should be made, that is, to take action on the privileges, such as a recommended revocation of all privileges or reduction of one or more privileges. The recommendation may also include taking action on the provider's appointment at the facility. The FPPE process for new providers is a wonderful tool to quickly identify the providers a good fit at your facility. The sooner a poor fit is identified, the easier it is to take appropriate action. The final option, and the most common option, is to accept the analysis confirming that the provider is competent to perform the privileges that have been granted and to convert the provider to the OPPE process for ongoing monitoring. The service chief's recommendation is made to the Executive Committee of the Medical Staff, and in turn, the committee makes a recommendation to the Medical Center Director for final decision and action. In concluding this section of this presentation on FPPE, let's end with further discussion on the FPPE for cause. Remember that these are the FPPEs that have been triggered, and a focused review has confirmed that there is, we'll start 15 over again. In concluding this section of the presentation, let's end with further discussion on FPPE for cause. Remember, FPPE for cause are the ones that have been triggered, and the focus review has confirmed that there is reason for concern. We talked earlier in the presentation that triggers are predefined, and if met, a focused review is completed to determine if the concerns can be substantiated. If they are substantiated, the decision may be made to place the provider on an FPPE for cause. It is very important to stress at this point that FPPEs should not be viewed as punitive. It is a process to be offered to providers as an opportunity to demonstrate improvement or to refine their skills. The FPPE for cause will be very specific to the provider and specific to the concerns and issues at hand. The FPPE for cause should never be a surprise to the provider, as there ideally should have been ongoing communication once the trigger was met and sharing of information from the focused review. When developing the FPPE for cause, it should be written, and it must have clearly defined expectations with benchmarks and milestones. It must clearly define that these are based on identified deficiencies. It must be clearly defined, i.e., that the provider will have an accuracy rate of 75% at the end of 30 days, 80% at the end of 60 days, and 90% accuracy at the end of the FPPE. It is noted here in the defined outcomes, if at the 75% at the end of 30 days is not met, the FPPE does not need to continue if there is still significant concern about the ability of the provider to improve. It must clearly define the expectation for what is expected to be maintained, what will be incorporated into the OPPE, not only for this provider, but all providers in the service. And it can its ability to practice. And finally, the FPPE for cause is time limited. It should not be extended. The provider needs to meet the expectations in the time agreed upon. Remember, the provider is already a trained provider. This is not a period of training. It is a period of improvement and demonstration. If the expectations are not met, movement must then be made to take appropriate action, which might include reduction or revocation of privileges. So now let's move on to the ongoing professional practice evaluation section of the presentation. The intent of the Joint Commission for OPPE performance on an ongoing basis rather than only at a 2-year reappointment process, thus allowing them to improve performance on a timely basis. The information that is to be used is to decide to continue, limit, or revoke any existing privileges at any time, and that not just to wait until the end of the 2-year credentialing cycle. The OPPE indicators that are used should address the provider's privileges. So as with the FPPE, the goal of the OPPE is to identify questions or concerns with the provider's practice early so that intervention can be made expeditiously and appropriately. As with FPPE, the underlying purpose of OPPE is patient safety and intervening when necessary on behalf of the patients that we serve. So for competency to be measured, it must first be defined. Competency is a two-sided equation. We're not going to talk about how privileges are developed in this presentation, but if they are developed with the idea of what qualifications the provider needs to bring to, and the service chief and medical staff leadership can define how the competency is going to be measured, the criteria to be used, then that leads right into the FPPE and OPPE process. We have to know what we mean by competency, and that's a two-sided equation. We have an expectation that the provider does enough of an area of practice to demonstrate the quality of care. It is an equation. This has long been something monitored in the procedure-based practice areas such as surgery, but it is true in other areas as well. In primary care, there may be a minimum number to a panel size because if the providers don't see enough of a certain area of practice, it may be more difficult to maintain competency. One area specific is women's health and the special needs of our women veterans. And just because someone does have the numbers does not guarantee the quality of their outcomes. OPPE should be organized and address the 6 general competencies which were originally identified by the ACGMB. These competencies are patient care and procedures, medical clinical knowledge, practice-based learning and improvement, interpersonal and communication skills, professionalism, and systems-based practice. These competencies are not weighted, and one is not defining above others. The overall performance and competency of the providers is evaluated by the sum of all of them, and the total picture portrays of your clinical staff members. There is an opportunity to standardize 4 of the 6 competencies across the facility and across services and subspecialties. These 4 are the practice-based learning and improvement, interpersonal and communication skills, professionalism, and system-based practice. We're going to discuss examples of these at the end of this presentation, but for a more thorough discussion in these areas, you may want to go to the Office of Quality, Safety, and Value intranet site and review under Medical Staff Affairs and review the Practitioner Privileging and Profile for Practitioner Competency, which you can find under Medical Staff Affairs and the Medical Staff Process. Additionally, you can find an Excel workbook with specific general ideas for each of the competencies that your clinical leadership may want to review. The remaining 2, patient care and procedural and medical clinical knowledge, need to be service and subspecialty specific and tied to the respective privileges for the service and subspecialty. The OPPE information that's gathered can be used for other purposes. The service chief can use it for positive things, such as recognizing good performance, as well as helping to set expectations for expected performance. Remember, the OPPE is to be objective, pre-approved, and uniformly applied. As such, it is easy for service chiefs to communicate the expectations defined in an OPPE and other potential uses of the information, such as performance reviews, tying it to performance pay, etc. The OPPE feedback should be provided in a positive way to support self-correction of providers who may be performing at a lower level than their peers, but not low enough to trigger a management review. As we talked in the FPPE discussion, it will allow for early identification and correction of performance that is not meeting the expectations. When the service chief is developing OPPE criteria for their service, it is important to often define who will assist in collecting the information for the service chief. When will it be collected and reported? Where will the information come from, such as the OR package, laboratory package, DSS, dashboards, etc.? And how often will it be retrieved, and how is it going to be shared with the providers? Remember that by definition, this is an ongoing evaluation, and as such, when contemplating these questions, it is recommended that the review cycle be no more than a 6-month period. Anything longer than that is not recognized as being ongoing. You hopefully have a document such as a medical center memorandum that defines the OPPE process at your facility. This document should talk about who reviews the information, when it is reviewed, and what is done when it is reviewed. Again, we don't always like to bring up the Inspector General, but they are looking at whether or not the service chiefs identify what information they use when making a decision to renew a provider's privileges, and how this information supports the decision that they make. In other words, does the service chief document that the OPPE supports or confirms the provider is competent to deliver the care they are privileged to deliver? If they are not, and the OPPE does not support it, what else can or should be done? The OPPE reviews, as with the FPPE reviews, can lead the service chief to make one of several recommendations. If there are no identified issues, the recommendation may be to continue the privileges in the OPPE process. If there are significant issues identified, again, hopefully caught very early and proactively, a trigger may be met, leading to a management review, which could include a focused review and possibly an FPPE for cause. And of course, the final actions from those could lead to a revocation or reduction of privileges. If care concerns are identified in the OPPE process which lead to a concern of an individual's safety, a summary suspension of privileges may be warranted in accordance with VHA Handbook 1119 to take the provider out of patient care until further review can be accomplished. Again, your local process should define who is responsible for what and when they are responsible for it. Remember that the provider profile, which includes the FPPE and OPPE information, any focused reviews that might have been completed, etc., is maintained under the same system of records as your credential files. So they are maintained under the Systems of Record Notice 77 VA 10Q. The provider profiles are the ultimate responsibility of the service chief and should be maintained where they can have quick access to the files. Under no circumstances should the information be integrated in the credentialing files while the provider is active at the facility. Once the provider leaves the facility and is no longer active, the provider profile can be incorporated with the credentialing file and processed in accordance with record management guidelines. So what else with the data? The Joint Commission is very verbal that OPPE is ongoing and not annual, so it must be done more than once every 12 months. And the VHA leadership has said at least every 6 months, as we stated earlier in the presentation. It is used for reappraisal at the time a provider's privileges are being reviewed and granted, probably every 2 years. The provider is not granted privileges every 6 months, but this is asking the service chief to make a decision as to whether or not there should be any change. The whole concept of the OPPE is to catch something early and maybe avert a bigger problem later on. If you catch something early, you can counsel someone. If you can't catch something early, you can make suggestions for a change in practice. If you catch something early, you can have a provider seek assistance. The whole idea is that the care and feeding of the healthcare professionals is expensive. And if we take a serious look at things and identify something early, we might be able to avoid an adverse action or even worse, a significant patient issue. We are often told that clinical staff look at the activity as an administrative one rather than a patient safety activity. It is important to be able to explain that this process is in place to protect our patients. It is also to assist the service chiefs in ensuring that the quality of care being performed under their supervision is acceptable. When documenting OPPE and FPPE, the Joint Commission expects to see minutes that specifically address for each provider and for each review whether or not the privileges should continue, be limited, or be revoked. The decision needs to be documented in the file. If the decision is to limit or revoke a privilege, such a decision would need to be made through a recommendation to the Executive Committee of the medical staff to the director, as only the director can grant or change a privilege. For the documentation, they expect to see at minimum that the service chief recommends continuation, a limitation of privileges, or a revocation of privileges. How you document within your files is a local decision. When there are no negative findings in the OPPE process and the decision is to continue, the review can be signed by the service chief and does not need to go to the Executive Committee of the medical staff, unless it is your local policy to do so. Obviously, if any change in privilege is required as stated above, it would need to go through the appropriate process in accordance with your facility bylaws. Finally, we get many questions related to whether or not this provider should be signing the OPPE, and the answer to that is that the provider should, if at all feasible, when there is no action to be taken. Since the review is the care that they are delivering, and feedback to the provider is a key component of this process, if the FPPE OPPE process is going to lead to potential privileging actions, the service chief should meet one-on-one with the provider, and a signature and a documentation of the discussion is very highly recommended. Again, as we just stated, it is important for the service chief to communicate with the provider. It's not always easy to meet with the provider every 6 months, especially if things are going okay. If the service chief doesn't meet with each provider, there does need to be some sort of documentation by the service chief as to how the information was shared with the provider, even if they did not meet with them one-on-one. So now let's talk about what information can be used. Unfortunately, there's a lot of information that is easily available to the service chief and is tempting for use in the OPPE and FPPE process. However, it is protected by quality assurance regulations 38 U.S.C. 5705 and cannot be used for any activity that is of human resource nature. Credentialing and privileging falls into this category. And the development of 38 U.S.C. 5705 is stemmed from an antitrust lawsuit of Patrick versus Burgett. In this case, in 1972, Dr. Patrick, who was a general and vascular surgeon from Oregon, declined an invitation to join a partnership and began an independent practice in the same town. Even though he was one of the only general surgeons in the town, the group practice, where he had declined to become a partner, referred patients as far as 50 miles away or further versus referring to him. They also declined consultations from him and refused to provide backup coverage. The partners gave him a difficult time, including peer review proceedings at the only hospital in town, leading to termination of his privileges at that hospital, essentially making it impossible for him to continue practicing in that town, where there was a population of only 10,000 people. Dr. Patrick filed against them, indicating that it was a violation of the Sherman Act, by initiating and participating in a peer review proceeding in order to reduce competition rather than to improve patient care. The court first sided with the defense, but the Court of Appeals reversed the decision. The final policy argument is that effective peer review is essential to the provision of quality medical care, and that any threat of antitrust liability will prevent physicians from participating openly and actively in the peer review proceedings. In 1980, based upon the decision and outcome of the Patrick versus Burgett case, the VA language was drafted that became 38 U.S.C. 5705. As a result, 38 U.S.C. 5705 protects our providers so that they can be involved in honest reviews of care provided by other providers in order to improve the quality of health care delivered or the utilization of health care resources. So how do you know whether or not the information can be used for credentialing and privileging activities? The test of whether or not it is 5705 protected is to evaluate if it meets one or both of the following. Was the review carried out by or for the VA for the purpose of, 1, improving the quality of health care, and or improving the utilization of health care resources? If the answer to one or both of these is yes, it is 38 U.S.C. 5705 protected and cannot be used for the OPPE and FPPE process. Here are some examples of the 38 U.S.C. 5705 protected information that might be tempting. Peer reviews for tort claims, mortality and morbidity reviews, occurrence screenings by utilization management, drug usage evaluations, blood use reviews, adverse event reports, infection control and surveillance, autopsy reviews, and process action team findings. There's a lot of data collected at your facilities, and a lot of it may end up in quality management activity. But for the most part, if you get this information before it gets into a 5705 protected format or purpose, you can use it. The only data that is protected from the point of collection is this QIP, the VASQIP, IPEC, and CART-CL. Any other data can be collected and shared before it goes to the quality management process. The good news is if you use this data and the data supports the privileges a provider has, you have the individual provider data that can be compared to the identified aggregate reports that quality management produces. So how can you use the information that's been identified, as we talked about in the slide previous? The answer is you cannot use information that's already been protected by 38 U.S.C. 5705. You have to rediscover it. As stated before, credentialing and privileging is reconsidered to support human resource activities. An example of rediscovery would be the VASQIP program for surgical outcomes. Provider-specific information from this program is 38 U.S.C. 5705 protected and cannot be used for the FPPE or OPPE purposes. Rediscovery of this information would have the information directly pulled from the OR package for the purposes of credentialing and privileging activities. If the information is not rediscovered and used for quality management activity, it can put the facility's quality management program at significant risk. The example of VASQIP that we talked about before is an example of rediscovery. So again, the provider-specific information cannot be used in this example of VASQIP. However, the de-identified aggregate information, and again I will repeat that, de-identified aggregate information from 38 U.S.C. 5705 protected information can be used as benchmarks and comparisons to the provider-specific information that you have rediscovered. Using the framework of the 6 general competencies identified on this slide and that we discussed earlier in this presentation, Several aspects of care and interactions with patients and coworkers should be considered. Clinical case or medical record review are useful but not sufficient to gain the picture as a whole. Critical to successful competency measure are fairness and efficiency. The collection and analysis of clinical data should be objective and performed in a uniform fashion for all similar providers. Whenever feasible, aggregate data should be compared to relevant local and national benchmarks. Competency measurements should also include information outside of clinical activities, but that are critical to the support of patient care and the facility, such as patient satisfaction, participation in relevant educational activities, participation in quality management and performance improvement activities, utilization management data, etc. What we will show on the following slides are sample lists of indicators that can be used for the practitioner profile. This list is not meant to be all-inclusive or mandated, but provides examples of indicators that can be considered. The selection of indicators should be a balanced approach and incorporate factors representing all 6 general competencies that are described. Indicators must be objective, with criteria defined in a manner that will measure current competence of the clinician who is a member of the medical staff. Indicators may support more than one general competency. It is important to emphasize that the overall goal is to ensure that patients are receiving quality care from competent staff. So when defining what will be considered under each of the 6 competencies, the review must address the provider's individual privileges. As stated earlier in the presentation, these practitioner privilege-specific indicators are best addressed under 2 of the 6 general competencies, patient care and medical clinical knowledge. The remaining 4 competencies, practice-based, interpersonal, professionalism, and system-based, are competencies that can be more standardized across the specialties, services, and medical center because they are more general. Facilities are encouraged to identify meaningful indicators for these broad competencies that apply to all privileged providers. So when deciding how you're going to measure the 6 competencies and which indicators will be selected, it's important to remember that just because we can measure something doesn't mean that it's meaningful or useful. Human nature is often good at things that are easier to obtain. Often what needs to be measured is extremely difficult to measure, so we move on to indicators that are easier to obtain that really have no statistical significance, accuracy, or relevance. Collecting and measuring information that is not meaningful and is not easily interpreted can lead to misunderstandings, misguided requirements, and resources being diverted from credible issues. When selecting the indicators for each of the competencies, each facility should determine what indicators are meaningful. There is no requirement for the number of indicators for each competency. More is not always better. 1 or 2 indicators that are well-defined may be all that's needed for useful feedback and assessment of the provider's competency. Once the indicators are defined, they should be reassessed routinely. An annual reassessment of the indicators is recommended to determine if they are still relevant and meaningful. If they are being easily met and have not been found to be useful in the assessment process, they should be replaced with a new indicator which better meets the needs of the service. Let's move now into more detail of 6 competencies. The first one that we will discuss is patient care. Patient care indicators demonstrate compassionate patient care that is appropriate and effective for the promotion of health, prevention of illness, treatment of disease, and at the end of life. As noted, you should address core, cluster, and specific privileges either here or under the medical clinical knowledge section. Examples of patient care indicators may include the appropriateness and complications with medications prescribed, procedures performed and outcomes, including complications, surgical procedures and any data analysis outside of the fast-quit process, timeliness for clinic procedures, timeliness and responsiveness to consults, compliments and complaints, patient satisfaction data, medical record delinquency, discharge timeliness, and blood product usage. Some more examples might include appropriate use of restraint, appropriate use of consults, infection rates, 360-degree evaluations, tort claims, clinical pertinence reviews, simulation training, resident supervision, and patient care measures that are already being collected that are provider-specific that would be applicable. And again, all this information must be discovered before it is U.S.C. 5705 protected. The next category that we'll discuss is the medical clinical knowledge. These are indicators that demonstrate a practitioner's knowledge of established and evolving biomedical, clinical, and social sciences and the application to patient care and the education of others. As noted, again, addressing the privileges, either here or under the patient care. Adherence to evidence guidelines is appropriate for the patient. That's one of the examples. Other examples include demonstrated selection of the most effective and appropriate approaches to diagnosis and treatment. Surgical procedures performed meet indications as per guidelines. Performance measures, peer recommendations, simulation training, appropriate informed consent use, appropriate use of sterile technique, hand washing, involvement in resident training, meeting CME requirements. There may be performance measures that are already being collected that are provider-specific that would be applicable, and a medical staff may want to establish additional performance measures specific to the specialty. The next is practice-based learning and improvement. These are indicators that demonstrate the ability to use scientific evidence and methods to investigate, evaluate, and improve patient care. Examples include demonstration of personal, specialty, and facility data for all general competencies for self-improvement to continuously improve patient care, meets continuing education needs, participates in quality improvement teams, peer recommendations, preparation, presentations of lectures, mentors, trainees, or peers, completes mandatory training, implements recommendations for quality improvement activities. The next one is interpersonal communication skills. These are indicators that establish an expectation and demonstrate evidence of skills that enable the establishment and maintenance of professional relationships with patients, families, and other members of the healthcare team. Examples include compliments and complaints, medical records delinquency, timeliness and completeness of medical record documentation, use of unapproved abbreviations, disclosure of patient events, responsiveness to staff, peers, nurses, and other staff, responsiveness to pages, responsiveness to consultation requests, peer recommendations, 360-degree evaluations, surveys of patients, arranging appropriate coverage when not available, resident evaluations, appropriate communication with physicians for co-managing patients. That they address end-of-life issues with patients, that they're providing clinical disclosures when appropriate, alerts management of significant adverse actions to ensure appropriate response, including institutional disclosures. Professionalism. These indicators establish an expectation to demonstrate behaviors that reflect a commitment to continuous professional development, ethical practice, an understanding to sensitivity to diversity, and a responsible attitude towards patients, profession, and society. Examples of professionalism include responsiveness to staff, responsiveness to pages, participation in the medical staff committees, participation in quality management activities such as RCAs and quality improvement activities, peer recommendations, maintenance of patient privacy, maintenance of security of patient health information, compliance with facility policies, arranges for appropriate coverage during planned absences, arranges for proper supervision and collaboration during planned absences, when in collaboration or supervisory agreement with an allied health professional, and timeliness, respectful of timeliness of clinic schedules, respectful of timeliness of meetings, participates in peer reviews, RCAs, committees, etc., accepts criticism and alters practice when appropriate, interacts with patients, their families, and staff with compassion and an understanding and appreciation of their needs and beliefs, absence of a validated disruptive or unprofessional behavior, and meets timelines for required or assigned tasks, such as H&Ps, clinic notes, and dictation. Systems-based practices. These are indicators that demonstrate an understanding of the context and systems in which healthcare is being delivered, as well as the ability to apply this knowledge to improve and optimize healthcare. Examples of system-based practice indicators include utilization management data demonstrates cost-effective quality patient care, such as the days of care, average lengths of stay, medication costs. Triggers for patient safety activities for medical errors, use of timeouts, and use of appropriate abbreviations. Disclosures of adverse actions and adverse events. Adherence to locally adopted quality and safety protocols. Appropriate use of IMED consent. Complies with handoff communication policy and medication reconciliation. So let's end the presentation with where are some opportunities for improvement been identified in reports that have been published in 2013. The OIG did a retroactive review of FPPE and OPPE process for new providers and new privileges and made the following. There were 2 recommendations for instances of FPPE not being initiated when new privileges were requested. There were 2 recommendations made for instances where FPPEs were not completed. That is, they were started, but there was no evidence they were ever completed or followed through. And there were 7 recommendations of instances where the FPPE process was not reported to the executive committee of the medical staff and then through the director. So it is very critical that when FPPEs are started, that there is a timeline, it is followed, and it is documented, and it is taken back to the executive committee of the medical staff in a timely fashion with a recommendation. And that recommendation must be documented and then forwarded to the director for appropriate action. There are also findings related to OPPE. There were 4 recommendations, all related to CBOC, where there's no evidence of an OPPE. Remember, the practice must be in place for all providers at your facility, whether they're at your main facility or if they're at a CBOC. There were also 8 recommendations specific to the lack of documentation by the service chief or the executive committee of the medical staff to reflect what is used to grant privileges. Again, it's critical when the service chief is writing their recommendations in VetPro that they reflect on the OPPE and FPPE process and what they use to make the recommendation. It is also important for the minutes of the executive committee to reflect the discussion and what was considered and what was used to support the recommendation that's being made to the director. There were 4 recommendations specific to failure to use aggregate data for providers with comparable or similar privileges. Again, comparison and benchmarking is important. And 2 recommendations specific to no service-specific criteria for privileges. So this concludes the presentation on OPPE and FPPE. In this presentation, we hope that you come away with a better understanding of the FPPE process, including FPPE for cause, the OPPE process, what information is 38 U.S.C. 5705 protected, and why it cannot be used for FPPE and OPPE, how you rediscover information that is protected, development of indicators, and the 6 general competencies that should be covered in the OPPE process. For further information, you are encouraged to look at the many resources and tools available on the Office of Quality, Safety, and Value intranet site under Medical Staff Affairs. I thank you for your time and your commitment to serving our veterans.